Good afternoon, everybody. Thank you very much for joining me today. Here with Healthmonics, we are going over the 2022 proposed rule insights, the impact it has on MIPS, the APP, and much more. My name is Michael Lewis. I'm a MIPS specialist here at Healthmonics, and I will run you through this entire program. Just a couple of notes before we get started. Handouts are available at the bottom of the screen, including the entire presentation today. I think it is a good idea for you to save that information as I will be going through the slides. However, there is a lot of information on the slides for this presentation because of the amount of information from the proposed rule. Secondly, if you have any questions, you can ask the questions in the box here through the GoToWebinar widget. And if we have an opportunity at the end, I will try to answer a few questions. But with time permits, I will get through to everybody after the presentation by the end of this week. So what are we going to review today? So today we're going to review the changes from the proposed rule. We are also going to discuss how those changes will impact you, as well as the future of the MIPS program and MACRA as a whole. So bear with me, there is a lot to go over today. All right, so CMS objectives for 2022 reporting. Once again this year, they're delaying a lot of the changes, mostly due to the reduced burden on providers digging out of COVID-19. So there is an opportunity here for us mostly to delay some of the changes that CMS had out that were planning to be made even last year are now being pushed forward. Keeping the momentum for the quality payment program moving forward, that's really important. So we have the ability here that they don't want to get rid of this program. They do not want it to slow down. So you'll see some major jumps in some of the information that we have and some of the data requirements moving forward that were not there before. So they want to make sure they're keeping this momentum moving forward. And the end goal is to drive providers towards MVPs and some of the APM models that are out there like ACOs. So some of the major changes, there's inclusions of new eligible clinician types, there's changes to the performance thresholds, there's new complex patient bonus, there are changes to the 3-point floor for certain measures, as well as changes into how some of the classes for each measures are. We'll go over that, and the removal of some of the bonuses that are available to you. A number of the PI measures had some additional changes to them. There are some new cost measures. The web interface has been added for another year, so you're going to have the opportunity to report through the web interface. And they're also delaying the MVPs for another year. So let's jump right into some of the changes that are going through. So first off, there are some MIPS reporting frameworks that you need to take a look at. So MIPS has 3 ways to report. Currently there's 2 ways, and then for 2023, there'll be a 3rd way that is added. So for MIPS, you could either be doing traditional MIPS, which many of you on the phone right here now have been involved in, and that could be group reporting or individual reporting or as an APM entity or even a virtual group, even though very few are part of what's called a virtual group. You could also be going through the APP performance pathway. We've gone over that a number of times in previous webinars, and we'll hit up a little bit on that in a couple of seconds here. But that you can report through group, individual, and once again through your APM entity and virtual group. And then coming in 2023 now, as I said, it was delayed another year, is the MIPS value pathways. So what are some of the changes? So the minimum threshold to avoid the penalty is increasing once again. So in 2021, the threshold is 60 points. And the projection is that in 2022, and what they're proposing is that it will be 75 points to avoid hitting a penalty. As you can tell, this is getting harder and harder. CMS objective is that the people that fall below are going to increase the amount of money and funds that are available to those that are above that 75-point threshold. As you can see here, the estimated return on what it looks like on the bottom left-hand side, you'll get a -9% all the way up to 20 points. And then you can see it increase from there on. It is scalable to where you are scoring all the way up to you are at 0 at 75 points, which you can see here. And then it moves up again to 89 points on a little bit of an increased scale. And then from 89 points all the way up, you'll see that the skyrockets in the amount of money that you can be reimbursed and the percentage you can be reimbursed in 2024. So what this is showing is that there is a possibility up to a 14% increase in your 2024. So that includes the $500 million as well as the money that is being paid out by the people that are being penalized. So it's a zero-sum program where it will bounce the books at the end of the year plus $500 million. So there is a lot of money to go get this year. If you've been performing well, this is an opportunity for you really to make out on what you have been doing. If you are performing below the thresholds, and for the last couple of years, for instance, if you just beat the thresholds of 45 or 30 or even 15 in previous years, moving all the way up to 75 points next year is going to be very difficult, and it is going to take a little bit of time and preparation and getting started earlier in the year. So what does it look like when it comes to reporting and how the categories are? If you are not exempt from any one of these measures, you can see here that the new split has quality and cost both at 30%. So that is the same exact amount. So all the work that you've done in the years past that has gone into quality, you're now working with for cost as well. PI is staying the same at 25, and the improvement activities are also staying the same at 15. If you are exempt from any of these categories, at this point, if you're exempt from IA, cost, or PI, all of that information will go over into quality for this year, same as the previous years. That's for traditional MIPS, by the way. Traditional MIPS for this, the summary proposed quality measures. So these are the quality measures and what they look like. There are, once again, a number of significant, or as they call, substantive changes. There are 84 measures that have substantive changes. Don't be frightened. A lot of those measures and changes are usually a claim or some type of change in how they are calculating the measure. They're not normally an entire change to the measure. Also here, you also see that they are planning on adding 5 new measures as well as removal of 19 measures in the system. Some of the changes that are here, the quality measures being added, you can see here there are the number of quality measures here, and then there also will be a new measure set change. New certified nurse midwife measure set will be added this year, as well as they are extending the availability of the CMS web interface for collection type in 2022 for MIPS. And then it will move on after that for MIPS users will need to report through either a registry or through their EHR. As far as the measures that are being removed, you can see here there are a list of measures, 19 measures, of which there are some pretty popular measures considering our history working with these measures. Measure 154, the falls risk assessment, is planning on being eliminated. I come from a dermatology background, and measures 137 and 337 were very popular in the dermatology realm. So it really is based upon what you are what your specialty is, and they're getting rid of a number of measures here. So be careful if you are planning on reporting next year to really check the measures and make sure there's nothing that's missing. So this is some of the more difficult information that we have, and really to go over and really to understand. So this is why I asked everybody to download the slide deck that you have there, so that you can really pay attention to this in the future and take a look at it and call us if you have questions. But CMS is anticipating a low reporting rates in 2020 performance period, payment year due to COVID, and that has pushed policy changes for establishing benchmarks. So the first policy hierarchy is the historical baseline period, 2 performance periods prior to applicable performance period. So what you're looking at here are your normal measures with your benchmark. So these are the measures that a benchmark can be calculated from historical baseline period, and these are the ones that you would normally have in you're used to. The performance period benchmark, however, is a benchmark cannot be calculated from historical baseline period, but 20 or more clinicians report on a measure and meet or exceed the case minimum of 20 cases during the performance period. So you will get a benchmark for that type of measure, so that it's a newer measure basically, or a measure that has not been benchmarked in the past but could be benchmarked based upon this year's work. Alternate historical baseline period. So this is taking a look at a measure based on the 2 years prior to applicable performance, but the benchmark can't be calculated from the historical baseline period because the measure has not undergone any substantive change in the time since the data was collected or has been suppressed in the baseline period. And then there's those measures, as you can see, policy hierarchy number 4 is no baseline, the subject to class 2 scoring policy, and we'll get into all of these a little bit further on the next couple pages, but there's a lot of information to go over. A benchmark cannot be calculated from historical baseline period, the performance period, or alternate performance period. So taking a look at the quality benchmarks a little further, we have currently there's a 3-point floor for benchmarks. If provider meets reporting requirements, so as long as it meets the 20 eligible instances and 70% completion threshold, so that's important, they cannot score lower than 3 decile points for a measure. So they are planning on changing that for next year, only for large accounts, so removing the 3-point floor for each measure that can be reliably scored against the benchmark and score the measure from 1 to 10 points. This is meant to be rolled out with MVPs, but since those are being delayed, CMS wants to continue moving forward. So what this is going to look like here is the class 1. So these are those normal measures that we just talked about. They have a benchmark, they meet the case minimum requirement, and data completeness. So those are most of the measures that are out there now. Currently, you get 3 to 10. They are proposing that you could get 1 to 10, score to 1 to 10 on that. So as you can see, most of their steps here are really reducing how well you can score on these measures. And by doing that, they're going to put extra pressure on people to score well. Class 2 measures are those with the benchmark and meet the case minimum, but however, they did not meet the data completion. In the past, you were able to get 3 points for this measure, no matter the size of your group, but moving forward, only small practices will be able to receive 3 points. So if you have one of these measures and you do not meet data completeness, you will get 0 points for this measure. Class 3, these are measures that are submitted but do not meet the data completeness threshold, even if they have a measure benchmark or meet the case minimum. So here, their MIPS eligible clinicians other than small practices will receive 0 points for this measure. Small practices will receive 3 points. Right, this is a little confusing, but I highly recommend taking a look at this sheet and this slide number 15 in the future so you understand where you are getting points. And then the new measure class is class 4. This is the new part and change this year. Measures that are in their first 2 performance periods in MIPS program that meet the data completeness requirement, but may lack a benchmark and may not meet the case minimum. For those measures that can be reliably scored against the benchmark, they will get 5 to 10 points. And for those measures that cannot be reliably scored against the benchmark because they lack a benchmark or do not meet the case minimum, we'll give you 5 points. This is urging providers to start reporting on newer measures and giving them the opportunity really to take a chance on a new measure to report well moving forward. So this is the same deck that we just saw on the previous page, but here what you're seeing, CMS is proposing to remove special scoring policies for measures that meet the data completeness requirements. So this is the class 2. If there is 20 eligible instances required and was not met, or the measure that is older than 2 years has no benchmark, small practices will be able to receive 3 points. However, large practices, which are more than 15 providers, will get 0 points. Topped out measures, if a measure is topped out in 2020 and topped out again in 2021 and still topped out in 2022, the score will be capped at 7 points. So by topped out, basically is meaning that more people are performing very well, providers are performing very well in these measures, and when they perform very well, the accuracy and the need for them to report is not as important across the board. So on to some of the bonus points that they're getting rid of. CMS is proposing to get rid of all the bonus points for high priority measures. So in the past, you were able to get bonus points for every additional high priority measure that you reported past your first one, as well as you were able to get 2 outcome bonus points past your first outcome measure. And you were able actually to receive bonus points for reporting more than 6 measures. Your 7th and 8th measure, for instance, could get extra bonus points without their calculating the measure in there. So they're looking to get rid of that. And they're also planning on removing the end-to-end reporting bonus points. So those are the ability to give you an extra point if you are taking data directly from a certified system into a registry or reporting it directly through your EHR and getting rid of the end-to-end reporting bonus point. Their rationale is that the bonus points were temporary, that they were planning on removing them for a while, and it simplifies the scoring. Majority of measures are high priority or outcome, so they continue to get rid of the regular MIPS measures over the years and have really left it, if you take a look at it, most of the measures are high priority or outcome, so it's basically leaving points up there for everybody. Bonus scoring, CMS proposes to keep the improvement bonus score. To be eligible, the MIPS eligible clinician needs to earn a quality performance category score of less than or equal to 30% in previous year for the 2022 performance period, giving you an ability to gain a couple extra points if you do better this year than the previous years. And that's been around for a little bit now. So the changes here, the move to 30% for the cost category is mandated by law. So this is one of the proposed rules that we're almost 100% positive is going to go through for this year. So it looks like all the information, as I said earlier, that you've spent time over the years going over quality when it was 60% of your score, now it finally will be even with your quality scoring for cost. The last couple of years, they have taken cost out of your score. But we want to make sure that everybody is very well aware that now with cost in there, there's the opportunity to really, you don't have as much opportunity to help your score out with quality across the board, and you really need to pay attention to cost as much. Ooh, that's fancy. All right, there's additional 5 new episode-based measures for cost. So that also includes 2 chronic condition measures. So the new episode-based measures, there's a melanoma resection measure, colon and rectal resection measure, as well as sepsis acute inpatient medical condition. That's going to add some specialties onto the cost score, like dermatology with the melanoma, and most surgeons are now going to be added into needing a cost score. How they have not been part of cost for the previous 2 years. There's also a couple of chronic care condition measures. You see here one for COPD as well as one for diabetes. The chronic condition episode-based measures are to expand on previously established framework for episode-based measures and they address unique factors inherent to the continuous nature. So you'll be able to see on the next page, I believe, what the chronic condition episodes attribution looks like. So here what you're seeing is that a new attribution framework, right? So this is new this year for identifying and confirming a clinical patient relationship for the proposed chronic condition measure. So each cost measure in the past has had an episode where there was a trigger event in the measure, and it usually lasted a certain amount of days. What the chronic condition one is going to do is that it's going to have vary in length for different patients, and it's going to span multiple years. So instead of it being something that's short term and looking at a certain window, it's going to expand that throughout the entire time. So what you see here is total attribution window can span multiple years, and it's for different, and it's the length can be different for every patient. The individual clinician's performance is based on all the episodes attributed to the individual clinician, whereas the clinician's group performance is based on all episodes attributed to the clinician group. If a single episode is attributed to multiple clinicians in a single clinician group, the episode only counts once towards the clinician group score. So that's it for cost. Those are the changes for cost. Now we're going to jump right into promoting interoperability. There are a number of distinctive changes in promoting interoperability, and I'm going to go through them as well. Provide patients electronic access to their health information measure. This is one that's been around for a while with PI. Currently, it requires that clinicians provide timely access for the patients to view or transmit health info online, but it does not specify how long it must be available or what happens in case the EMR vendors change. What they are proposing is that the access to the PHI is indefinite and not for a defined period of time, beginning with information receiving from January 1st of 2016. What this really is this is going to hit your EMR vendors and their ability and need for them to bring data into the patient portals that comes from your previous EHR. This will allow provider or patients to see their data no matter if you change your EHR and from your practice. So a lot of EHRs don't have that ability right now, but with this change, I'm sure this might be pushed out, but with this change, it's going to force EHRs to start looking into that as a solution to what they're looking for. All right, public health and clinical data exchange objective. So currently, clinicians can select any two of the 5 measures from the public health and clinical data exchange objective to report. Now what they're saying is that they are requiring 2 specific measures. So you have the immunization registry reporting and electronic case reporting. This change is being pushed and fueled by COVID-19, as they have found that it has helped in the total quality of patient care. Proposed scoring for the public health and clinical data exchange objective. So these are the objectives that we were just talking about. For the 2 measures, if providers answer yes to both, they will receive the full 10 points. If providers answer yes for one measure and are approved for an exception on the other, they will receive the full 10 points. However, if they answer one or more no or fail to report on one of the measures, they will not only receive 0 points, but they actually will get 0 points for PI. Just like any of the other PI measures, if you don't have an exemption and you receive a 0 in any one of those categories, it will give you a 0 for the entire promoting interoperability. If exclusions for both points will be distributed to the provider to patient exchange objective. CMS is also proposing not to get rid of those other 3 measures that they've asked you to track over the years, but add them as bonus points and the possibility for 1 per provider. So you could do 1 more of those other measures for bonus points. SAFER guide. So SAFER is the safety assurance factors for EHR resilience. And what they're for is to support the ability of healthcare providers to address their EMR safety. So proposed, they're adding a new SAFER measure to protect patient health information objective, obviously part of putting all of this information in online and giving patients the ability to look at it and providers to grab that information. from the health information exchanges, it increases the need to protect the patient health information. So MIPS eligible clinicians must attest to conduct an annual self-assessment using high priority practice guides. And the measure will be required but not scored. It is exactly like the SRA for the last couple of years, where you need to check a box and attest that you did it. However, it doesn't give you a point. If you do not do this, you will get a 0 in PI. So the safer guides can be completed at any point throughout the year, very similar to the SRA. You can wait till the end of the year for either one of those. I don't suggest that. So CMS will assign a weight of 0 only in the event. And this is for taking a look at MPs, PAs, CRNAs, and CNS, does not submit any data. So if they do submit data, they will be scored on promoting interoperability, and they are part of the group scoring. So if you are reporting as a group and they are in there, they will get a PI score. CMS believes that having these clinicians types using CERT and submitting data for the promoting interoperability performance category is important, and they feel like they should be held to those same standards. CMS is encouraged by the increase in number of these specialists that are submitting data for promoting interoperability throughout the years. It believes that the low numbers warrant the continued reweighting of promoting interoperability performance category. So basically, they're happy that more people are doing it, but it's still not enough. So the plan of attack is to continue to give them the option of getting out of it. However, with the increased pain caused by some of the changes in the quality reporting, I highly suggest that if you have a certified EHR and you can report PI, this might be the perfect opportunity moving into 2022 that you could take 90 days and do very well with the reporting of PI, and it will help your score throughout the year. I do believe it's finally getting to the point where scoring perfectly in the PI category may be easier than scoring well for an entire year in the quality category. So some of the other specialists that we've discussed in the past: physical therapists, occupational therapists, your speech language pathologist, qualified audiologists, clinical psychologists, registered dietitians, and nutrition professionals. All of those, CMS is proposing to continue the existing policy of reweighting the promoting interoperability performance category for the 2022 performance period and the 2024 payment year. This has been the same thing since they've been added to MIPS 3 years ago, I now believe, for most of them, 2 years for some of the others. So they will be reweighting the permitting interoperability to the quality area. Clinical social workers and certified nurse midwives are being added. So I know we probably have a number of psychologists on the phone here today. Know that if you have clinical social workers as part of your groups, which can take up a very large majority of your practice, they will be added into MIPS next year and need to be reported on under group reporting, or if they qualify as individuals. I personally don't understand the certified nurse midwives section, considering they're not seeing a ton of Medicare patients. CMS is proposing to add to clinical social workers and certified nurse midwives as MIPS eligible clinicians. I just said that. They are not currently eligible to participate in the Promoting Interoperability Program to earn incentive payments for meaningful use or CERT, or receive the reduced Medicare payments for failing to meet CERT. So they're going to fall into the same category as the ones that you see above. So now we're going to go into the APM performance pathway, otherwise known as the APP. This is where there were a number of major changes in what they're planning on doing. So first off, the APM performance pathway was introduced for the 2021 year. So providers can report for it through in 2021, requiring that eligible MIPS APMs and ACOs participating in Medicare Savings Program begin transition towards reporting quality via the APP instead of the web interface, which has been around for a while. The web interface allows you to report on 248 randomly selected patients for an individual for your measures. There's 10 measures for that. The new way that this will be working is that they're going to have to report on all patients seen by any providers at the ACO. So down to 3 quality measures, as well as 3 other measures that are going to make up your quality score. But you need to be reporting on all patients seen by any provider at your ACO if you're part of an ACO. So one of our partners, the National Association of Accountable Care Organizations, or NACOS, has communicated ACO concerns. So basically, they put out that they were going to get rid of the CMS web interface in 2021 and or for 2022 year. And NACOS, along with a number of their ACOs, did a survey of their people, and 77% indicated they don't have the infrastructure in place to aggregate their data. There's privacy concerns and concerns over the BAAs, as well as some concerns at reporting ECQMs on their patients that are not Medicare would be a HIPAA violation. CMS has come back to all of those and basically said it's not a HIPAA violation. There should be no issue with the BIA. And privacy concerns, we've been doing this in MIPS forever. However, they did decide that they would take this first point where 77% indicated they don't have the infrastructure and give them some more time to report this. So moving forward, there has been a change in the performance year now. So in 2022, there's multiple options. 2023, there are multiple options. And then come 2024, there is no other option that is available. So for performance year 2022, you're going to report either your 10 CMS web interface measures, or you're going to report your 3 ECQM measures. Same thing for 2023. However, 2023, you do have to report 1 ECQM in 2023. So that is a new addition. And for those that don't know, ECQM and CQM are your registry or EHR measures. CMS web interface is directly reported to CMS by the client, by the practice, rather than through a third-party administrator like your EHR or a registry. And then, as I said, in 2024, they're actually going to plan is to move forward that the only way to report will be through ECQMs and CQMs. So totally eliminating the CMS web interface throughout the year. The reason they are planning on doing this is because they believe that ACOs need to pay attention more towards their non-attributed patients, so your non-Medicare patients, and that quality should be done for patients across the board, and that they've been doing it in MIPS for a long time, and they plan on continuing to do it with APP. So once again, this is to push it back to 2024. However, in 2023, there is a need to report at least 1 measure. The other thing that I didn't mention here is that if you report both options, CMS will give you the higher of the 2 scores, as well as there are some pretty easy ways to report the 3 ECQMs and CQM measures. If you do that and you meet some thresholds that we can go over if you have questions, you could meet your quality benchmarks in 2021 and 2022. This is a little bit of what I went over, but I definitely did want to provide you with the resource on it on page 460 of the proposed rule. This is the exact line that comes from it as part of the phase in, and in order to transition ACOs to reporting all payer ECQM, MIPS, CQM measures. For performance year 2023, we would require an ACO to report on at least 1 ECQM and CMS measure that meets the data completeness and the case requirements, in addition to the CMS web interfaces. So this is important information for those that were planning on pushing back their need to report through a registry or through their EHR, giving them the opportunity right now to make some changes for the future. Whoop. All right, so what is next? That's what we're up to. So what's next? The next big thing is there are the introduction of the MIPS value pathways. So it was originally supposed to start in 2021. It was pushed back, I think, multiple reasons. I don't think CMS was ready for it. I don't think the vendors were ready for it, as well as COVID being around has changed, obviously, a lot of new things that they were trying to implement. So they are proposing to push it back once again for another year. So not 2021, they're looking at, or 2022, they're looking at 2023 to start the MVP. So this is the future of where the program is going. It's going to move towards a aligned set of measures. It's going to take 3 to 5 years to fully implement. I tend to think it's going to be in the 5+ range, but that is because of the changes that they're making to it. The whole idea of this is that the cost and the quality and improvement activities are going to be bunched together so that specialists and so forth and different groups can have the same quality measures, cost measures, improvement activities with a foundation of having the promoting interoperability below it. I apologize for that. So this is an example. This is a diabetes example. This is the one they use within the final rule and where it's moving. So in the current picture, what you see here is everything's very different. There's 4 performance categories and it feels like 4 different programs. What they're doing is that they want to reduce the burden on providers by making it feel like there's just one section. So in next year, right, not this year, so in 2023, so 2 years from now, you're going to be able to see these reports. So for instance, an endocrinologist is going to report on fewer measures, a subset of measures that have only to do with the diabetes patients, and there will be cost measures, improvement activity measures, and quality measures that are all needed to be reported under one of these branches. The plan is that CMS is going to have more data for you and be able to provide your results faster, and it's going to reduce the burden on endocrinologists. As we know, for years and years in this program, specialists have needed to report on measures that don't make much sense in their practices, whether it is, as I used to work with the dermatologist, it used to be dermatologists needed to report on the flu and pneumonia vaccine. Never made much sense to me when I was doing it. And still as an overall program, there are a number of measures that just aren't needed for specialists to report on. So that's a big thing that they're trying to get away with. And the goal is to continue to reduce the burden as well as increase the number of measures and really stick to one point and how those measures can work. So performance category measures in endocrinologist diabetes pathway are more meaningful for their practice. That's what they're really trying to get at. So here you can see what that looks like. This is the diabetes one that we were talking about. The quality measures would be the A1C, the medical attention for nephropathy, as well as evaluation of controlling high blood pressure for the quality measures. There are the improvement activities that are available for you here. And then you'll see that there are total cost of care. So you have your TPCC, which is your total per capita cost, as well as your Medicare spending per beneficiary measures as costs. Some of the other specialists that are here and through the MIPS value pathways will have the opportunity for these to be more specialized and some more of the episode measures rather than the 2 major measures there for cost. So a little bit about what we are and what we do and why would you choose a registry. So more measures, a registry like MIPS Pro has over 200 measures, gives you a better option for your specialty, allows you to pick the measures in which you score best. You get to deal with the experts, so work with MIPS experts as they help you navigate through all changes and obstacles. You combine data from multiple EHRs, so those that are in ACOs or those that are merging with other practices and so forth. We can take all your data from multiple healthcare technologies and make it into one. You get to track your data all year long to allow for performance improvement. You are still eligible for at least 21, the end-to-end bonus, and you can report on all ECQMs moving forward. And we pride ourselves here on the ability to dig into your data and attack your gaps in care, work with our account teams to make sure that we are getting you the best score possible, as more and more of your revenue is based upon your results of these programs. Big tip that I have, I think I've given this every year for the last 2-3 years, is that to start early. I think that's the biggest thing right now, is that there are a lot of people that aren't starting early, and they're catching up on their data and they're not performing where they need to be because the measures have changed, or the measures are harder to score on or not available, and they're being caught by surprise at the end of the year. So the biggest part that I say is that start early, get signed up with whatever program you're working with, start tracking January 1st of the year. You'll be able to look at the providers and the patients and measures right away, track who's doing poorly, where you may need performance improvement, and so forth. You can also track more than 6 quality measures. I definitely recommend doing that, as there will be a number of changes to the measures that you're doing. If not in 2022, there'll be more changes in 2023, so preparing yourself can be very useful. So here's an example of what it looks like in our system, taking a look at our live dashboard. So we get data from your EHR on a daily or nightly basis. We have the information in our system, and here you can see where it is compared to your decile score. We have the ability here to break it down by individual provider. You have the ability to email those providers their scores and how they're working in the system. You get to work towards attacking those gaps in care and performance improvement. And the main goal here, obviously, is for better patient care, as well as higher quality scores and an increase in your revenue. You could dig down into that information here, taking a look at the performance improvement. What you see here are the individual patient visits, as well as where they are getting credit for your METs and not METs for each one of these measures. So for instance, here we're taking a look at the measures, measure 48, and those patients that are not met for that measure. So if you have any questions, you could give us a call. Our best-in-class US-based support team and integration team are here to help reduce your burden of quality reporting, and we're here to help you provide the highest quality healthcare to your patients. And we are introducing HealthMonic's MIPS Cost Analytics. MIPS Cost Analytics is the first and only technology platform that provides current year payment data for Medicare patients. So as I stated earlier, cost is important, and moving up in it, we are the first company really to help you attack that data, understand where you can make changes throughout the year, so you're not surprised with a poor health MIPS cost score at the end of the year. And how we're doing that is showing the estimated MIPS cost score throughout the year. It gives actionable insight into each cost measure. We're providing your anticipated attributed patients and episodes, providing you individual HCC scoring, and allowing you to easily identify patients and providers with the largest impact on your cost score. Don't miss out and take a look for our, I can't believe we're saying this, our October webinar series. It feels like it was just the middle of the summer, but we're halfway through September here, so don't miss out on our October webinar series. If you have any questions, my name's Mike Lewis. You can reach me at contact@healthmonics.com, as well as the number that you see on the screen. That is not right. It's just 888-720-4200. You can reach us through that number that you see there. So thank you very much today. I'm going to ask if you have any questions to write them in here. I have a couple that I'm going to take a look at, so everybody just give me 1 minute while I read them over. Okay, a couple questions here. And please ask away if you have any more. There weren't too many today. Does CMS have a list of qualified electronic case registries? They do. You can have that. You can get that through the QPP website. Will there be a recording? Yes, I'll get this recording out to everybody within an hour of that, along with another copy of the slide decks in case you forget to do that. For MIPS value pathways, will all specialists have to report separately than as an overall group? So the MIPS value pathways are definitely still up in the air with what they're doing. So when we get the information, we will let you know. But as of right now, There is not a distinct yes or no to that question. The slide deck, asking two people asked for a slide deck. It should be the first handout that says 2022 proposed rule webinar final. That's available there. And once again, I will send it out to everybody in an email later on this afternoon. There's a question about the COVID vaccination measure. I need to get back to you on that, so I will get you an answer to that once I take a look at it. I want to make sure what I think is correct is the correct answer. I don't have any further questions on here. If you have any other questions, feel free, as I said, to contact me at contact@healthmonix.com. Those emails will come directly to me, and I can get you the answers that you need to. Everybody, thank you very much for joining us today. I hope you are enjoying your September. We look forward to helping you moving forward. Have a wonderful day and talk to you soon. Thank you.